So, still talking about drugs that are used to suppress inflammatory and immune reactions, and we're talking about drug used in the management of rheumatoid arthritis, and osteoarthritis. So, what is rheumatoid arthritis? It's a chronic disease that is characterized by pain, stiffness, inflammation, swelling, and sometimes destruction of the joints. That's rheumatoid arthritis. And then osteoarthritis, arthritis characterized by degeneration and sometimes hypertrophic changes in the bone and cartilage of one or more joints, and a progressive wearing down of opposing joint surface with consequent distortion of joint position, usually without bone stiffening. Okay, so that is osteoarthritis. Rheumatoid arthritis, there is pain, stiffness, inflammation, swelling. Osteoarthritis, you can see there is at least one or more joints, and it is progressive. It will start slow and it will be going up like that. There's going to be distortion of the joint, okay, but there's not going to be any stiffening of the joint. You can see this is the health joint. Osteoarthritis looking like that. Rheumatoid arthritis, you can see again the appearance. So there is a stiffening, meaning that someone fails, they can't move on that joint, more like the bones have ended up connected. That's what happens in rheumatoid arthritis. So rheumatoid arthritis is caused by an inappropriate immune response that results in chronic inflammation in and around joints. The immune system has responded too much, and that causes this inflammation, which is chronic. The chronic inflammatory process includes the production of a number of cytokines and inflammatory mediators that will cause the destruction of the cartilage within the joint. Pharmacologic treatment of the rheumatoid arthritis includes then treatment of the acute pain. If someone comes with a pain at that particular time, the treatment of the inflammation and the inhibition of the immune system, because that's what is causing the problem. So glucocorticoids such as prednisolone or cortisone, these are potent anti-inflammatory agents and are also immunosuppressive. Glucocorticoids may be administered orally or injected into an affected area. Glucocorticoids, these are just drugs that they are helping, you can see, in inflammation. Because the thing is that when you look at the prostaglandin pathway, you are starting from the cell membrane, the phospholipid that is there, and then it's being converted into uh, you are going to have before you can go to the leukotrienes and the prostaglandins, you are having arachidonic acid. So that stage you can inhibit it using glucocorticoids before you can go to the arachidonic acid. I mean, before you can go to the leukotrienes and the prostaglandins. What is the cause of joint inflammatory disease? The disturbance in immune response in rheumatoid arthritis may also be relevant in osteoarthritis and in gout. Just a disturbance in immune response. So in rheumatoid arthritis, activated T cells and cytokines released from macrophages will result in a cascade of events that will lead to the proteolytic enzyme release, which will start now damaging cartilage. Prostaglandins promote synovial vasodilatation and they will worsen, they will exacerbate the pain. Okay, prostaglandins that are released. This is why when you are treating, you are inhibiting the entire pathway, because at the end also you produce the prostaglandins which worsen the pain. So what are the principles of drug management or drug treatment of rheumatoid arthritis and osteoarthritis? The chronicity of inflammation, joint disease such as rheumatoid arthritis necessitates long-term follow-up and management within a multi-dimensional framework aimed at preserving the patient's quality of life. You can say it's important. We're talking about quality of life here, and there is multi-dimensional framework, because it's not just a doctor that's going to be involved here. You want to involve physiotherapists, okay, occupational therapy, counseling, podiatry. All these people should come together, because besides the medication, this person also is having some problems with movement. So you want physiotherapy to come in. Pain perception is actually influenced by psychological factors such as the patient's belief in their ability to cope with or control the effect of their disease. So patient education and support is going to also be important. Okay. And actually psychology is very important when it comes to medicine. Patients, if they come to the hospital, even if you've just not told them, you can just prescribe Panadol. As long as you've not told them, or you put it in something that is fancy, when they just take, they'll feel better. Not because the drug is working, but because of psychological thought. The doctor has prescribed, so this is going to help me, and they feel better. Clinical guidelines from the British Society of Rheumatology, n- the National Institute for Health and Clinical Excellence, and Scottish Intercollegiate Guideline Network now reflect the requirement to use disease modifying anti hematic drugs, okay, anti-rheumatic drug. We call them the DMARDs. So we're going to be using these disease modifying anti-rheumatic drugs, the DMARDs, together with NSAIDs from disease onset, because the majority of patients who develop joint damage do so within the first 2 years. So just when the disease starts, you want to use the NSAIDs with the DMARDs. Okay. So rheumatoid arthritis, you have got non-pharmacological treatment like physical therapy, so patient counseling, lifestyle, smoking, exercise, ideal body weight, okay, drug adherence, surgery. These are non-pharmacological. Some people end up worsening the condition because they don't want to adhere to the drugs. And then you can also give them the NSAIDs, only symptom improvement like pain and stiffness, but no influence on disease progression. The disease can still be progressing like that, and only use the symptomatic or until diagnosis is established. Someone is just having pain, you don't know what is really wrong with them, if it is this condition or that condition. At that point, you can be giving them the NSAIDs. You can also give them the glucocorticoids. Now, these are non-specific immunosuppressants, and they have got rapid systemic disease modifying effect, but long-term side effects. So rapidly they are going to have disease modifying effects. They'll help, but over a long period of time, because these guys actually inhibit our immune system, they suppress our immune system. The thing is that we become weak. You are prone to getting sick because your immune system is down. You also have the DMARDs, the disease modifying anti-rheumatic drugs. This is a medicine that interferes with the signs and symptoms of rheumatoid arthritis, and the target is inflammation to prevent further joint damage. Okay. So the key points in the treatment of rheumatoid arthritis and osteoarthritis: drugs used in inflammatory joint disease are aimed at control of symptoms and the prevention of joint damage. So the DMARD should be used early in the course of the disease to prevent joint damage. These drugs do not have significant side effect profile and require appropriate clinical and laboratory monitoring. Okay, they don't have significant side effects, so they are good. So about the symptom, remember we've said that we give these drugs to control symptoms and to prevent damage. So symptom modification, you can give simple analgesic drugs that stop pain like paracetamol, okay, to supplement other therapies, but alone are relatively ineffective in inflammatory arthritis. If you give paracetamol alone or an NSAID alone, it might not help. You are giving it as you are also giving other drugs that should be helping now with the actual problem that you have. Compound analgesics like cocodamol will give little extra analgesic benefit. Their use is complicated by adverse effects. That's why you want to avoid these. Like there's confusion, especially in elderly patients. You have got some other stronger pain medications like tramadol. Tramadol is an opioid together with morphine, codeine. We have got what we call pethidine, the amphetamines. We call these as opioids. We'll discuss them in neuropharmacology, the first topic in neuropharmacology. Okay, so these drugs are good, but the problem is that they cause constipation. And the thing is that these drugs do not have an effect on disease progression. You'll be stopping pain, but the disease will still be progressing. NSAIDs act on a variety of ways, but we already know their function. Their function is they inhibit the COX-1 and COX-2. They are going to be prescribed the lowest possible dose for the shortest time frame required and should be encouraged to reduce their NSAID use from regular to as required. So you don't want to be using NSAIDs very often. So instead of using them regularly, only use them when required as soon as it is feasible to do so, because you want to prevent side effects later on. You can also give steroids. Steroids are used in inflammatory joint disease by the oral, intramuscular, or intraarticular routes. And steroid therapy is an effective means by which the inflammatory response can be suppressed and symptoms alleviated or at least better. But again, steroids are not effective for long-term strategy because of the significant side effect associated with long-term use of these steroids. And steroids are used early in the disease for acute symptomatic treatment when the DMARD therapy is being initiated. Okay, that's when you also use these. And you normally want to give them using the intraarticular route to target a particular problematic joint instead of giving systemic. Because the problem is that if you take them by mouth or via IV, they'll go through the out through or via IM, they'll go throughout the body and they'll end up causing these side effects. The disease modifying anti-rheumatic drugs, the DMARDs, are used in the management of inflammatory arthritis to achieve disease remission, to remove the disease, and to slow down the development of joint erosion, which leads to damage and deformity. The most common used ones are methotrexate, you have got sulfur, salazine, hydroxychloroquine. Okay. There is good evidence for the use of these three agents in combination to achieve better disease control. So, if you really want to help someone, instead of giving these drugs as individual drugs, you want to combine the three drugs. It will actually be much, much more better. Okay, let me pause a bit. Is there any question so far? Any question? Okay, so the DMARDs have got are less commonly used. Okay, so you have got other DMARDs which are less commonly used like leflunomide and myoclizine, which is the intramuscular gold. Other drugs like chloroquine, oranofin, penicillamine, these ones are rarely used. So just remember at least methotrexate, okay, and then you just think of quinine, hydro hydrochloroquine, or just think of chloroquine itself because we've been hearing about chloroquine a lot, isn't it? Just put hydro in front. So establishing effective DMARD therapy within 12 weeks of diagnosis is of key in the management. You want to make sure that within 12 weeks of diagnosis, you establish effective DMARD therapy. A treat to target approach is commonly adopted, with the activity of arthritis being assessed at each visit using a composite score such as the DAS28, and therapy escalated until good disease control is achieved. When you are giving the drug, you can escalate therapy so that you can at least go a bit higher or faster so that you can control the disease. So treat to target, you treat to the point which you want. Hydroxychloroquine originally was developed as an antimalarial drug and has been used in the treatment of rheumatoid arthritis and connective tissue disease since 1950. Useful role in combination with other DMARDs when its action is synergistic. Okay, they are going to be working together. 1 plus 1 is equal to 3, especially in patients with milder disease who don't tolerate more potent drugs. How hydroxychloroquine works is maybe by lysosomal stabilization and inhibition of phagocytic function. Okay, you stabilize the lysosome. The lysosome is what ends up eating up organelles, eating up other things. So once you stabilize them, they are going to stop doing that, because the problem here is that you are eating up the joints and such. And hydroxychloroquine or chloroquine is absorbed orally, taken up by many tissue, and then very slowly excreted in the urine. Adverse effects are very rare with this one, but there is a retinopathy which is rare because of gradual accumulation of drug in the retina. And this is dose dependent, and the risk increases in renal failure, because remember these drugs are excreted from the kidney. So if someone is having kidney that is failing, it means that excretion is very difficult, and so the drug will end up accumulating. So in order to assess when someone is taking this drug, they should be on annual visual acuity. So you should be checking their visual uh, function. Another adverse effect is a rash and bone marrow toxicity, though they are very rare. Sulfasalazine is effective and relatively safe anti-rheumatic drug, and it's used in HLA B27 related arthropathies like reactive arthritis. So this is the principal anti-rheumatic agent, sulfasalazine. The adverse effects include skin rash, GI upset, headache, occasional leukopenia, the reduction in white blood cells, and thrombocytopenia, reduction in platelets. So blood abnormalities occur early in the course of the treatment and reversible when the drug is stopped. So therefore, when you are treating someone using this drug, you need to monitor the complete blood count and liver function tests 2 weeks. Okay, after 2 weeks, every after 2 weeks for the first 3 months, every after 2 weeks for the first 3 months, and then reduce to 3 months after 12 months of treatment. So for 3 months, you'll be checking every 2 weeks, and then after 12 months, you start now checking 3 months apart to assessing if there is any problem. So be doing this complete blood count. Male patients again should be warned of a reversible lowering of sperm count. It is reversible. but they should be warned in case they can't have children at that point. And then there also be orange tinge discoloration of body fluids. There will be 12 week before parents start to see benefit. This is supposed to be the patients. So it takes about 12 weeks before the patient can start to see benefits. Methotrexate is a folic acid antagonist, and it has become the anchor drug in the treatment of inflammatory arthritis. It's administered weekly, either orally or subcut, and it's highly effective as monotherapy and in combination with sulfur, salazine, and hydroxychloroquine. Minor adverse effects that methotrexate has is that it limit dose escalation, okay, and the effects include nausea, anorexia. This is where someone is losing weight. They're actually afraid of eating because of the fear of gaining, so they end up losing weight. Hair thinning and metallic taste in the mouth. Okay. So how does methotrexate really work? There's this pathway for folic acid. When you take folic acid, it will be broken down to dihydrofolate, and then dihydrofolate will be converted to tetrahydrofolate, which is involved now in making DNA. So it can actually inhibit the conversion of dihydrofolate to tetrahydrofolate. The enzyme here is dihydrofolate reductase. The serious adverse effects for methotrexate includes myelosuppression and hepatotoxicity. There is problem in suppression of the blood system, okay, the formation of blood cells in the bone marrow, and then hepatotoxic. Renal failure, if methotrexate accumulates, can happen. Also interstitial lung disease, okay. So patients that are taking methotrexate should have a baseline chest radiography, like their normal radiography, so that later on after treatment you can be checking. And this drug can also be potentially teratogenic, able to cause cancer. And so male and female patients need to use effective contraception. When you're taking this drug, use contraception so that you don't have. It's teratogenic, not really carcinogenic. Carcinogenic is a bit to cause cancer, but can cause teratologies in growing children. So I want to make sure that there's contraception so that when you're taking these drugs, you don't have children because of the ability to cause the teratogenicity. Methotrexate should also be co-prescribed with folic acid to reduce the risk of adverse effects, because the thing is that methotrexate is inhibiting the folate pathway. So also prescribe with folic acid so that there is no much reduction in folate. And then it's commenced at a low dose, and then you escalate it according to response. The onset of action is around 8 to 10 weeks. That's when it starts working. As we said earlier, you'll be giving it, and then it will take like 12 weeks before the patients can start to feel good. Full blood count and liver function tests should be monitored on a 1 to 2 weekly basis until the dose is stable, and on a 1 to 2 month basis thereafter. So you should make sure that you are monitoring full blood count, liver function test, as we said earlier, because one causes problem with the blood system. Leflunomide inhibits mitochondrial enzyme dihydroorate dehydrogenase, which is involved in the synthesis of pyrimidines. Okay, it thereby inhibits lymphocyte activation and growth, because actually the lymphocytes that are destroying our cells because of the reaction. There's this over immune response. That's the same with the folate pathway that we're inhibiting using methotrexate, because folic acid is involved in the synthesis of DNA. So we want to stop the synthesis of the DNA, okay, or the RNA, so that you stop the growth of these cells. So leflunomide is actually an effective DMARD in rheumatoid arthritis. The adverse effects, which are minor, rash, headache, diarrhea, hypertension with a relatively small rise in mean rise in arterial pressure. This drug is also hepatotoxic and myelosuppression. So the US Food and Drug Administration, FDA, they brought this even in the exam last year. What does FDA stand for? So that is Food and Drug Administration. It is put in category X. Category X, that's dangerous. Okay, the way they classify these drugs, you have got category A, B, C, D, and then category X means that it is teratogenic. So you need to use contraception. Okay. Its metabolites have a long half-life and a washout with cholestyramine is used in the case of significant adverse effect or prior to conception. So if you take this drug a lot and you think it is leading to these bad effects, you can remove it from the body using cholestyramine, okay, or prior to contraception. You want to start giving these contraceptives first, you can clean this drug. Monitoring the full blood count and liver function is required every 2 weeks for the first. We said so. This one is for the first 2 months, and then after the first 2 months, later on you'll be checking every after 8 weeks the full blood count and the liver function test. You also have what is known as GOD. GOD is as effective as methotrexate, but the problem is that it is toxic. It was a good choice for patients with abnormal liver function because it is excreted in the kidney, but is now rarely given. It is given by deep IM injection after a 10 milligram test dose. Minor adverse effects include rash and presents in many forms, including oral ulceration, proteinuria, okay, protein in urine, secondary to a membranous glomerulonephritis. There is also bone marrow toxicity, which is potentially fatal, okay, and can develop suddenly. There's also vasodilatation, orthostatic hypotension, like when you stand, your blood pressure gets to 4, can follow this drug, especially in those patients that are also taking S inhibitors. Okay, so basically that is it about this topic. There's a question here that you can answer. A 40-year-old female with no known past medical history other than suspected rheumatoid arthritis present for evaluation for her pain. Patient reports monitoring stiffness, swelling and tenderness of her joints in her hands, shoulders, knee for over 6 months. Also reports fatigue and a maternal family history of rheumatoid arthritis. She brought in her old record which show laboratory and clinical criteria sufficient for the diagnosis of rheumatoid arthritis. She has not been following up with her primary care physician or her rheumatologist and has been trying to self manage with over the counter ibuprofen and acetaminophen. On examination, she has synovitis of both hands, wrist, shoulder, and knees. She has some early changes of rheumatoid arthritis, such as ulnar deviation of the digits of her hands and a few rheumatoid nodules on her arm. Hence, you start her on oral prednisone and methotrexate. What is the mechanism of immune suppression mediated by glucocorticoids? What is the mechanism of action of methotrexate? Remember, so the glucocorticoids interfere with cell cycle of activated lymphocytes, lymphoid cell, and activation of apoptosis in some lymphoid lines. So you interfere with cells cycle of activated lymphoid cells, and then you also cause apoptosis in some lymphoid lines. Mechanism of methotrexate, it inhibits DNA synthesis by inhibiting dihydrofolate reductase, which will stop the conversion of dihydrofolate to tetrahydrofolate. So that is it for this class.